about the anatomy of the the biliary system, the hepatic arterial system, the portal venous system. Okay, so if you are aware, and you can see that hepatic artery proper before is that the gastroduodenal artery. Okay, so this is the gastroduodenal artery. There is a branch from the hepatic artery. So after giving branch the gastroduodenal, then it forms the hepatic artery proper. So in that, so if you see there down, so you see you can see that every structure of the portal triad is going behind the pyloroduodenal junction. So the pylorus and the duodenum. Okay. So and you can see that the portal vein is going just behind the neck of pancreas. Okay, so you can see the neck of pancreas behind which the Bruce vein is there, that is the portal vein. And then if you see the uncinate process of the pancreas, which is coming all the way towards the third and the fourth part of the duodenum. You can see that behind the portal vein. So the neck of the pancreas behind which is the portal vein. So you can see that all the portal triad goes all the way behind the pyloroduodenal junction. Okay, so now the common hepatic duct, the common bile duct, and the pancreatic duct. So they all, the common hepatic duct and the common bile duct is formed by the cystic duct joins the common hepatic duct, and then the common bile duct will be formed. And the common bile duct and the pancreatic duct will join together, and then they open into the ampulla in the medial border of the duodenum. So if you see the classification of the choledocal cyst, see type 1. I show you the picture. See, type 1 is cystic or fusiform dilatation of the CBD. So type 1, there are three types. Type 1A, can you see there? Type 1A, there is a fusiform dilatation, and then the cystic duct is opening into the dilated part, okay? And then some part of intrahepatic right and left hepatic duct is also dilated. So that is about type 1A. If you see type 1B, you can see a cystic dilatation at the middle part of the CBD, where the gallbladder and the rest of the biliary tree is normal. So that is type 1B. And type 1C, where you see the similar pattern like type 1A, but the dilatation, the fusiform pattern is a little bit smaller in size. And then the cystic duct is again open into the dilated part of the common bile duct. So this is type 1 type of choledocal cyst. And then you talk about type 2. Okay, so type 2 is the, you can see here, it is the diverticulum. Okay, so that's the diverticular part. You can see there is outpouching of the common bile duct wall. And then type 3 is the cystic dilatation limited in intraduodenal portion of the distal CBD. Can you see that? See, it's an intraduodenal portion of the distal part of the CBD, where the pancreatic duct is also opening in that dilated part. Very difficult to treat. Okay, it's a very difficult situation. That is known as choledococele. You also call it choledococele. So if you say type 3, you can intraduodenal part which is dilated, and it's called as choledococele. And then type 4A and type 4B. In type 4A, both the intra and extrahepatic duct is dilated. Type 4B, only the extrahepatic part of the multiple dilatation but extrahepatic part. And type 5 is the Caroli's disease, where only the intrahepatic part is dilated. So multiple dilatation, so Caroli's disease. So there are various types of the choledocal cyst. Okay. Now we'll go into the introduction. Cystic dilatation throughout the biliary tree. More common in Asians, more common in women. Frequently diagnosed in infancy or childhood. Associated with biliary cancer. See, why we are so worried about choledocal cyst is its association with biliary cancer. 10 to 30% of the choledocal cyst gets converted into cholangiocarcinoma. Okay, so choledocal cyst, why we are worried? Because it can turn into cancer. how it can turn into cancer is that because of repeated infection and inflammation of the mucosa of the common bile duct will turn that into malignancy in a due course of time. So by the time a person develops choledocal cyst diagnosed during infancy, and then later in adulthood, around 25, 30, 35 years age, you may get the person getting cholangiocarcinoma. Okay, so now this I have told you already, and then classifications I have already told you. It is known as Todanis classification. So Todanis, Todanis classification. Okay, so there are various types, type 1 to type 5. Okay, as I have already told you. So pathogenesis, the cyst can be congenital cyst. Okay, so fetal viral infection may have a role. So cyst formation may be the result of ductal obstruction or distension during the prenatal or the neonatal period. Okay, so it is a congenital. So where the proliferation of embryologic biliary epithelial cells is unequal before the bile duct cannulation is complete. So that may give rise, so it's an epithelial cell problem, which can give rise to the choledocal cyst. Acquired, how you are going to get acquired? So it may be the result of abnormal pancreatico-biliary junction. So abnormal pancreatic biliary junctions will be in a congenital form, but later, due to that, the patient may develop choledocal cyst. So it's a congenital anomaly, APBZ, abnormal pancreatico-biliary junction abnormalities. Okay, so it is APBZ. So it's a congenital anomaly, and then its prevalence is 0.03%, and it is present in about 70% of the patient with biliary cyst, and maybe a significant risk factor for malignancy with the cyst. So even though without cyst, if the patient has an abnormal pancreatico-biliary junction, then the patient is more prone for developing cholangiocarcinoma because of the reflux of the pancreatic juice into the distal part of the common bile duct. Okay, so reflux of pancreatic juice, which is very, very toxic, containing a lot of bicarbonate, amylase, trypsin amylase, and lipase. So that may cause some changes to the biliary epithelium, causing malignancy. Okay. So you can see that abnormal pancreatico-biliary junction abnormalities. So APBJ. Can you see that? So when before it drains, both the ducts combines and drains into the second part of the duodenum, what will happen is that there will be some problem. Can you see in the second picture, the distal part of the common bile duct, it has developed a choledocal cyst in the proximal part. Distal part is very, very narrow, and it is joining to the pancreatic duct in a straight manner. Can you see that? So it is joining in a straight manner outside the duodenal wall. Okay, it is joining outside the duodenal wall, so there will be a long common channel, more than 1 centimeter. So they call it more than 1 centimeter long common channel. So that will give rise to reflux of the pancreatic juice into the biliary tree and causing the cholangiocarcinoma, being a risk factor. So clinical presentation of choledocal cyst. So two things you have to be remember. It's a congenital or it is an acquired secondary to abnormal pancreatico-biliary junction abnormality. So that's the cause of causing a choledocal cyst. So clinical presentation, the patient will develop jaundice, pain in the right upper quadrant, and an abdominal mass. Sometimes the choledocal cyst can be a huge one. I've seen few cases in the children's where they have come with a pain, jaundice, recurrent pain, jaundice, fever, and there was a mass, big mass in the right upper quadrant. Clinical presentation will present before the age of 10 years, most of the cases. The infants with biliary cyst, they will have conjugated hyperbilirubinemia because of the defective excretion, the cyst will not have a normal peristalsis. So there will be problem, stasis of the bile and the excretion, and there will be problem with the sphincters. So that incoordinated sphincters will give rise to stasis, and then there will be problem with conjugated bilirubin will rise and failure to thrive and an abdominal mass. The triad of pain, jaundice, and abdominal mass is found in up to 63% of the infants with choledocal cyst. Okay, the most common presentation, abdominal pain, recurrent cholangitis. I told you about recurrent cholangitis. That is the reason why they develop, because of the toxic pancreatic juice and the bile salts with having stasis in the cystic area that will be toxic to the biliary epithelium, and that give rise to, so that initially they give rise to recurrent cholangitis, and then later they develop into malignancy. Pancreatitis and the gallbladder, the biliary, the common bile duct stones, obviously. When you operate on a choledocal cyst, most of the time we get stones in the common bile duct. Rarely they present with intraperitoneal rupture, bleeding due to erosion into the adjacent vessels, portal hypertension, secondary biliary cirrhosis due to prolonged biliary obstruction and recurrent cholangitis. And in addition, if you see the type 3 cyst, that is the choledococele, the intraduodenal part of the common bile duct gets cystically dilated. So when intraduodenal part gets dilated and becomes huge, it can cause obstruction, gastric outlet obstruction. Okay, which compresses on the duodenal lumen. Okay, so what are the investigations? Ultrasound, transabdominal ultrasound, or you can do a CT cholangiography or a CT abdomen. Endoscopic ultrasound is coming up. So if it is a very small size, you may not be able to do an endoscopic ultrasound because you require a very small scope for that. And intraductal ultrasound, after then doing an endoscopic ultrasound, you can again send one more probe and do an intraductal ultrasound. ERCP and MRCP. MRCP can be diagnostic modality, very sensitive. Transabdominal ultrasound sensitivity is 71 to 97%. It may not detect type 3, that is choledococele, and type 5. Okay, type 5 is the Caroli's disease, where there are multiple small dilatation of the intrabiliary radicals, which maybe if it's less than 1 centimeter or less than 5 millimeter, the CCT may miss it. So it can miss it. Okay, so okay, and if you do a Doppler, you can see here the vascularity is, you can see, and computer tomography, as I have said you, okay, then it is very useful in determining the extent of intrahepatic disease in type 4A, okay, where you get both intra and extrahepatic cystic dilatation, or type 5, that is Caroli's disease. So in that case, extent of involvement, if there are multiple cysts, you can know with the CCT, which won't be able to be see, but MRCP can tell. Even if CCT, and most of the time their sensitivity is similar with regard to MRCP in diagnostic these two types. So, and then it can also tell you about the malignant change, the CCT, because if you inject the contrast, and then the contrast enhancement will be seen in some areas where there are malignant changes. CT cholangiography, highly sensitive. Okay, for detecting the biliary tree, not the pancreatic duct. See, CT cholangiography, the picture, how clear it is. Can you see that? Nice picture. which will be able to tell you what type of choledocal cyst it is and where it is and the extent. Nice one. So endoscopic ultrasound. Yes, this is also one of the modalities, but it is more sensitive for a choledococele, that is intraduodenal part of choledocal cyst, or the distal part of the choledocal cyst, mainly the extrahepatic biliary cyst. Okay, what is usually the distal part. See how the endoscopic ultrasound will show. See, the scope is passed like an endoscope and into the first part of the duodenum, and you can see that probe that is the radially like a disc. There will be an ultrasound which will be going around, and then you can see the image, and you can see nicely see the cyst, choledocal cyst with a stone. You can see in the picture here, that is a black picture here. There is a common bile duct shown here, and then the stone inside and then the cystic dilatation of the proximal part of the common bile duct. Okay, so this is the picture which will be seen, and then you will see the endoscopic ultrasound, which is very, very famous nowadays, okay, for diagnosing the periampullary diseases. Okay, in the pancreatic head or in the distal part of the CBD, if you want to diagnose something, then and then also in the body of the pancreas and in the tail, when the scope is in the stomach, you can nicely see the different types of cystic changes in the pancreas. So endoscopic ultrasound, very good for diagnosis. So some of you may become a radiologist or may become a gastrointestinal surgeon or an gastroenterologist mainly. So gastroenterologist, they do an endoscopic ultrasound, they do an endoscopy and see, and then some people, like I've seen few people who only do endoscopic ultrasound, take biopsies, put in stent, all sort of things they do, and then make the life of a surgeon easier. So gastroenterologist, they're very, very advantageous, and an endoscopic ultrasound, mainly for esophageal disease, pancreatic disease, and the periampullary diseases. Very nice. Intraductal ultrasound. So after doing the endoscopic ultrasound, you can even push a small catheter which has an ultrasound probe in it into the biliary tree. Okay, like see, you can see an ARCP scope, and then in the scope tip there is an endoscopic, intraductal ultrasound probe is there, which can be sent into the biliary tree and see the details of the, like you can see in the right side of the picture, you can see nice the common bile duct and the pancreatic duct detected by an intraductal ultrasound. I think intraductal ultrasonography is not available yet in Nepal. Okay, only in very few centers in the world, not everywhere in the world, maybe in US or maybe in some European countries, or I don't know whether in India as well. India, I don't think they have got an intraductal ultrasound yet. Okay. Hepatobiliary scintigraphy, HIDA scan. You must have heard about HIDA scan, which will tell you about the biliary tree, obviously. So it's sensitive in 100% in type 1 cyst, but HIDA scan, we don't do it in a regular basis to diagnose a choledocal cyst. Okay, so telling what HIDA scan may not make much sense with regard to choledocal cyst. See, you can see the HIDA scan, how nice pictures are seen, but we don't do it routinely to diagnose a choledocal cyst. Cholangiography, direct, that is percutaneous cholangiography, or an endoscopic during ERCP, we can inject a dye into the biliary tree and do an cholangiography. So these are the things when you are doing some intervention like ERCP, doing any sphincterotomy. Before doing that, we'll do an cholangiography or pancreatography and then see what are the things. If there are stones, we remove it. So during a therapeutic procedure, we do a cholangiography. Okay, see now how the cholangiography can show you the biliary tree nicely to see. Okay. MRCP, very, very good investigation to diagnose choledocal cyst. Very nice, 73 to 100% sensitivity. Can you see that? Nice one. MRCP, before doing any intervention to the patient, I do routinely write MRCP to diagnose a choledocal cyst. See, that's nice picture. You don't have to do any intervention to do MRCP. You just have to put the patient on the inside the machine, and then the machine will take a picture like you have injected a contrast. You don't have to inject a contrast, and then any fluid containing cavity is seen white. You can see the bile is there inside the biliary tree. So you can nicely see it as a white, but you are not able to see the vessels. You can only see the intestine and the biliary tree in MRCP. Can you see that? Nice, okay? So you without injecting contrast. So nicely seen the MRCP picture, okay? So what is the management? So management is you remove the cyst, do the excision of the cyst, and whatever you remove it, then you have to reconnect it. So if you remove a common bile duct and the common hepatic duct, only the right and left hepatic ducts are remaining, including the confluence, and then you connect the intestine into that. So do an Roux-en-Y hepatico-jejunostomy. Okay, so with hepatico-enterostomy means that means jejunostomy. Enterostomy means you connect the intestine. So that's okay. So if a patient has cholangitis, you manage cholangitis with antibiotic, do an ERCP, put a stent, and drain the infected bile. Okay, because the sphincters are not working properly. So once the patient is all right, then send the patient for MRCP and find out what are the things, and then plan for surgery. So you do remove the cystic dilated part, whatever is possible, to reduce the chance of developing carcinoma in a later date. So whatever part is possible, you remove it and do an portoenterostomy so that there is no more reflux of the pancreatic juice into the biliary tree, and the biliary tree drains very properly. So you have to make a good anastomosis with the bile duct. So type 1 is the cystic fusiform dilatation. Type 2 is the diverticulum, and the type 4 is the extrahepatic choledocal cyst. Most of the cases type 4A or type 4B. Okay, so in that situation you do a resection of the excision of the choledocal cyst, and sometimes if it is located only to the one segment of the liver, then you can remove the segment of the liver and do an hepatico-jejunostomy. Okay, so in sometimes very huge cyst, in that case what will happen is that you only remove the anterior wall of the cyst, because the posterior wall of the cyst is attached to the portal vein and the vessels very densely. So when you try to remove it, then you can injure the portal vein. So in that case, you remove the anterior wall, whatever is possible, and then just do a mucosectomy. You remove the mucosa of the posterior wall, and just leave it like that, so that the whatever part is attached to the vessel will get atrophied once you remove the mucosa and the vascularity is cut off. So you leave it the posterior wall, the outer wall, and then whatever is remaining the bile duct, you make a portoenterostomy. That's a hepatico-enterostomy. Type 3 is a choledococele, where you do a ERCP and do a sphincterotomy and drain the choledococele. Or sometimes you can do an endoscopic resection also, and that is done by gastroenterologist. And then type 5C cyst, choledocal cyst, that is Caroli's disease, where only the intrahepatic is there, which may require in a long term, because of repeated infection in that area, the liver will go into cirrhosis, and then the patient may require liver transplantation. So liver transplantation is the answer for the problem with the type 5 cyst with cirrhosis of liver. So alternative to surgery, when the patient is a very old patient now, okay, and the patient is very poor, patient is in sepsis, you cannot do any surgery, patient is very weak. In that case, you may do a ERCP, do a sphincterotomy, and drain the bile duct for temporarily and plan for surgery later. Can you see that? The choledocal cyst being excised. Okay? And then how you make an anastomosis is that you remove that cyst that is on the left side of your screen, you remove that dilated part, and then once you remove it, and then you connect it to the jejunal loop, that is bluish thing is the jejunal loop, and then into the hepatic duct So that is hepaticojejunostomy. Ru-and-Y because there is a Ru limb which is going into the hepatic duct, and there is a Y limb that is that is you have to reconnect it, the duodenum and the proximal jejunum. So that is known as Ru-and-Y hepaticojejunostomy. Complications: cholangitis, biliary stone formation, anastomotic stricture, residual debris in the intrahepatic bile ducts, intrahepatic bile duct dilatation, and malignancy. That's it. Okay, did you understand? Some of you can tell me what if you have not understood anything. That's all about choledocal cyst. You should know, and with regard to the choledocal cyst, okay. Okay, any questions? Yes. Somebody speak, huh? Any questions?
No, sir.
Yeah. Yes?